branches we'll be learning. Regarding the other branches which are possible to block with the help of the ultrasound are one maxillary and other one is the mandibular. Though these processes are basically extensions of the blind techniques, but nowadays as fluoroscopy is much more convenient, especially for the mandibular division block, that is why nowadays the mandibular division block through the blind approach or the ultrasound guided approach is not that popular. Maxillary branch block, yes, sometimes it can be done. So let's discuss the most commonly done blocks, mainly the supraorbital, infraorbital and medial branch. So in short, let us discuss the anatomy because there is no scope to discuss in very detail. So trigeminal nerve dividing into three branches. The first branch, the ophthalmic division, it goes through the superior orbital fissure, and after going through the superior orbital fissure, it divides into three branches. One goes to the lacrimal gland, which is known as the lacrimal. One goes to the nasociliary branch, which gives branches like anterior ethmoidal branch, posterior ethmoidal branch, and long ciliary nerve. They goes in medial side of the orbit. And the third branch, they forms, that's also known as the frontal branch. It goes at this point and they forms the supraorbital and the supratrochlear nerve. So when we are looking for the supraorbital nerve block, we are going towards the supraorbital foramina, through which a branch from the frontal nerve comes towards the forehead and supplies this area. And frontal nerve again is a branch from the ophthalmic nerve. Ophthalmic nerve is a branch from the trigeminal nerve. So these are the three branches that we can see. Similarly, the maxillary nerve or the maxillary division again gives multiple branches. First branch, it gives an intracranial branch. So which goes into the intracranial space and supplying the meninges. So first branch is very easy and it has gone intracranial branch. Then the nerves comes out to the foramen rotundum, and after coming out at the level of the foramen rotundum, it comes into the pterygopalatine fossa, and from the pterygopalatine fossa, it gives branches like pterygopalatine branches, from where we are having the sphenopalatine ganglion. From sphenopalatine ganglion, it gives branches like the greater lesser palatine nerves. There is also a lacrimal division of it, and then it gives two branches above at this point, that is known as the zygomaticotemporal and the zygomaticofacial. Then it enters through the inferior orbital fissure, and after entering the inferior orbital fissure, or sometimes just before entering, it gives two more branches. One is the posterior alveolar nerve and other nerve continues as the infraorbital nerve, and then it gives another two branches before exiting from the infraorbital foramen. So there are two terms, one is the infraorbital fissure which is at the posterior side, and then the infraorbital foramen which we are having at the front. Just before coming to the infraorbital foramen, it gives the middle and anterior alveolar nerve. They all supplies the maxillary alveolus process and the upper teeth. Now the terminal branch, they comes out as the infraorbital branch, then it gives the infraorbital branch, superior labial branch and supplying to this area. So any malignancy, any neuralgia at this region, maybe a postherpetic neuralgia, so that can be blocked by blocking the infraorbital nerve. Similarly, any condition of the forehead, for example, if there is a scar neuralgia, if there is a trauma, we want to do the suturing somewhere here. So whatever these conditions, we can block at this point at the supraorbital nerve. And the third branch, which is known as the mandibular division, it after coming out gives the meningeal branch. Unlike the second branch, the mandibular division first comes out through the foramen oval, and then it gives a meningeal branch which goes back to the cranium through a separate foramen. Can anyone tell that name of that foramen through which it returns?
Foramen spinosum.
Foramen spinosum, and this is the nervus spinosus that returns. After that, from the main trunk, it gives some muscular branches and one sensory branch. Then it divides into anterior and posterior divisions. And from anterior division, it mainly supplies to the muscles of mastication, namely the masseter, temporalis. So these muscles are supplied by the anterior division of the trigeminal nerve, and also the lateral pterygoid. Whereas from the posterior division, it gives a tweak to the medial pterygoid. Apart from this, all the branches of the posterior division are sensory. They supplies here as a lingual nerve. Then it supplies the tongue. Then it goes as the inferior alveolar nerve, which again comes here from a small foramen that is known as the mental foramen, and there is also an incisor branch, and also it supplies the inferior alveolus. And only one branch is actually given from the anterior posterior division, which is motor, that is supplying the buccinator. So that was the more or less division of these nerves. So if you look at the trigeminal nerve dividing into first three branches, then ophthalmic division, again dividing into three branches: frontal, lacrimal, nasociliary; frontal dividing into supraorbital and supratrochlear; lacrimal dividing into the lacrimal gland and supplying the portion of the upper eyelid. Nasociliary branch gives long ciliary, posterior ethmoidal, anterior ethmoidal, and the infratrochlear nerve. So these are the branches from the ophthalmic division. Maxillary division, again it divides into multiple branches. Zygomatic, I have already told that the zygomatico-temporal, zygomatico-facial. From the pterygopalatine, greater palatine, lesser palatine, nasopalatine and pharyngeal nerves. Posterior superior alveolar nerve that I have told just before entering the inferior orbital fissure it gives. Then infraorbital nerves, which gives the middle superior alveolar nerve, anterior superior alveolar nerve, and then the terminal branches that come out to the intraorbital foramen are the inferior palpebral, lateral nasal, and the superior labial. So by blocking the infraorbital nerve, we can block these areas, these branches. So these are the all divisions of the maxillary division. And mandibular division, first branches from the trunk. Here remember all other branches V1 and V2, they are all sensory, but whereas V3 has motor components. From the main trunk, it gives a tweak to the medial pterygoid and tensor tympani and the tensor valli palatini. Anterior division gives and supplies the masseter, temporal, and nerve to the lateral pterygoid and buccal nerve, and which is the only sensory part of it. Whereas the posterior divisions gives the auriculotemporal nerve, lingual nerve, and inferior alveolar nerve. And from the inferior alveolar nerve, one small branch is only motor, which is supplied actually to the anterior belly of the digastric and mylohyoid, and all the divisions are sensory. Okay, among which we can block only the mental nerve from the superficial and through the ultrasound. For rest of the blocks, either we have to rely and go to the foramen oval, or we have to go posterior to the, it's actually the same area going into different directions. So we have to go ultimately to the main mandibular nerve trunk by which we can block. But as today we are discussing mainly the ultrasound guided block, so in under ultrasound we can block three nerves most reliably. So I am not going into the details of the trigeminal neuralgia that we have already discussed. So in this picture you can see this is the frontal division, which is supplying to the becoming the supraorbital and the supratrochlear nerve. Now to block this nerve, this is the sensory area of the nerve, so any pain originating from this area can be blocked. What are the indications? I have already mentioned a few indications like trigeminal neuralgia, which is involving mainly the ophthalmic division, then herpes zoster ophthalmicus, then scar neuralgia of this area, then post-herpetic neuralgia, laceration repair, different procedures, and burn at this area. So for these regions we can block the supraorbital nerve. Now patient positioning is usually patient should be supine and slightly you can keep the head straight or slightly to the opposite side, it doesn't matter, and use either a hockey stick probe, which is a high frequency probe, or you can use a high frequency large probe. The advantage of hockey stick is that as the footprint is very small, so if you are using hockey stick, there are more possibilities that you will be able to put the probe in line, but otherwise you have to put the probe out of needle out of plane, but it doesn't matter because it's a very superficial nerve, so it doesn't causes much problem if it is going in plane or out of plane, it doesn't matter much, and all sterile things should be required. And we will be searching at this region, okay, just at the supraorbital margin. You can try to palpate it, it is palpable, and usually before putting the ultrasound, we palpate this area and we try to figure out where the supraorbital foramen is. Remember, even if though we have ultrasound, but always it is not very efficient technique to every time search first with the ultrasound, because something can be easily felt with your fingers. Okay, so this is such an area which is more easily felt with your fingers. So just first feel where it is, then try to see, and once you are there, you try switch on the Doppler, you see the artery, supraorbital artery which is associated with the nerve is there. And after this, either you can go in plane approach. In plane approach can be accessed by the two ways. One, if you are having such a large probe, in that case take the foramen in just one side of the probe. So that means I will be taking it as maximum as to this side, so that my needle part will be very small, or I can go out of plane, come to this area, aspirate, and then inject local anesthetic steroid solution. And if you are doing for an laceration repair or something surgical procedure, you can just give ropivacaine or bupivacaine, and volume is very less, usually 1 to 2 cc is good enough. Okay, and usually that much volume is good enough for an anesthesia at this point. Okay, so that is the supraorbital nerve block. Complications are very rare, which may include hematoma, for which you have to check before that there should be no coagulation abnormality. There are chances of intravascular injection, for which we can aspirate and we can check the dye spread. Accidental eye globe damage, it is not easily possible unless and until you are actually doing it very blindly and doing here, putting your needle here and there. Otherwise the chances is very less, and chance of infection, for which you have to follow a very aseptic technique. Now coming to the infraorbital nerve block, here the sensory supply goes to the eyelid, lateral part of the nose, part of the upper lip, part of the upper incisors, canine and premolars, and portion of the labial gingiva. Indications mainly include the trigeminal neuralgia involving the veto division, but not as a whole, only to this area, postherpetic neuralgia, facial trauma, dental and maxillofacial procedures, and chronic facial pain syndromes. Here also the technique is almost similar. Patient should be supine, head neutral, same transducer, linear transducer, either hockey stick or plain linear transducer, and try to go into the infraorbital foramen, find out again the artery, and we will be able to see the artery at this point. Rest of the procedure is exactly same. Complications are also exactly same. So there is nothing to much think about it. It is a very simple procedure and can be done when required. Ultrasound is definitely improving the accuracy. In case you are intravascular, it might show. If there is a formation of hematoma, it will show. So ultrasound helps along with the blind procedure. Now the third one, the mental nerve block, which is the portion of actually V3 which exits near the mandible via the mental foramen, which most commonly position between two premolars, that is the first and second premolars, and usually 2 to 3 centimeter lateral to the midline. So it will be almost at this point. Okay, try to palpate your premolar, and just in between the first and second premolar it will be. So here start scanning from the alveolus process, go a little down, we will be able to see the mental foramen. Here sometimes it is a little bit difficult to locate the artery, but it is easy to locate the deep within the bone, which is the mental foramen. So in most cases we see the mental foramen. If we are able to see the artery, then it is fine, but even if we do not see the artery, we have to put the drug at this point in the foramen after aspirating, that we are not injecting in any vessel. and indications are similar, like the trigeminal neuralgia involving the mental nerve division area, post-herpetic neuralgia in the lower lip or chin, facial laceration lip yards, chronic orofacial pain, and dental and maxillofacial procedures. So here you have to block it. Here also, just ask the patient to rotate the head slightly to the opposite side, and then with the linear transducer, focus and try to see the mental foramen. Once you are able to see the mental foramen, then you put your needle again either in plane approach or out of plane approach. Here in this picture you can see, we can also see the artery. So just go close to the artery and then inject 1 ml solution around it, and most commonly for therapeutic it is 1% lignocaine most commonly injected. For diagnostic and therapeutic you add with the steroid. Regarding the neurolytic, definitely neurolytic solutions here can be used, but remember in certain cases it might produce the complication associated with a neurolytic solution. Okay, so that could be there, like differentiation pain and post complications, whatever happens in most of the chemical neurolytics might be there. But yes, for the management of the chronic pain you can use neurolytic, you can go for the radiofrequency ablation as well. But remember, when in most of the cases in trigeminal neuralgia, we prefer going to the gastrin ganglion because the longevity. If you do a branch block, usually the duration of pain relief is comparatively less compared with the gastrin ganglion block. So sometimes a number of physicians usually say, why I should do a gastrin ganglion block? It is so deep, it is close to the brain, there are so many risks. But the main thing here comes the duration of pain relief and the quality of pain relief. When you are blocking at the level of the ganglion, the quality of pain relief is much better. The patient's recurrence rate is much less. But whereas if you go for the branch blocks, usually the recurrence rate is very high. So that is a problem, but sometimes yes, if it is a limited disease, if you have some problems near to the foramen oval or close to the gastrin ganglion, for example, as a big aberrant artery. In one of my cases, I got an aberrant vertebral artery which enclosing close to the foramen oval. So it was impossible to go close to the foramen oval. So their patient is having a pain in the maxillary division, fortunately. So what we could do, we could do a specific maxillary nerve block. So these are the techniques sometimes need to be employed and need to be changed on case to case basis based on the patient condition and the best patient interest. So that we have to do every time. Complications are almost similar: nerve injury, hematoma, intravascular injection, infection, transient paresthesia. In clinical parts, definitely they are also the same. Always aspirate, see under ultrasound, and then only inject it. So that was more or less maxillary nerve block. At this stage, I should not suggest you to do under the ultrasound. So we have already shown you how to do under the fluoroscopy. So unless and until you are very expert in the ultrasound, I should not suggest this procedure to do. Okay. And number of studies are also very limited. So I am not going into details to discuss this maxillary nerve block under ultrasound. But these three blocks, what I have shown, they are very good and that you can do in your practice. So Dr. Roy will be showing these three blocks first. Then we'll be moving towards the cervical spine. Mainly two procedures we'll be discussing in the cervical spine. Most commonly done procedure, one is the greater occipital nerve block and the other one is we'll be discussing today is the medial branch blocks.
Sir, aberrant vertebral artery we will know from MRI.
Yes, definitely MRI angiography. If plain MRI is showing, that is good, but otherwise if it is not showing, go for the MRI angio.
So MRI angio we have to do for every, like we are doing
MRI angio is not done every time, but MRI is done in all cases. Remember, nowadays when it is available, before doing any procedure, we do an MRI in trigeminal neuralgia.
Sir, and do we shave the patient's beard like mental foramen, and or do we go through the hair like needling?
Uh, I could not get your question actually.
Sir, ultrasound guided we are saying block mental foramen when that when we are keeping the needle, like whether do we shave the hair of the patient?
See, previously it was thought that shaving is essential. So in all surgical procedures, shaving is done. But nowadays it is not considered that essential. rather you clean that area with the betadine, and that mostly we do, and use a sterile gel instead of the normal ultrasound gel. Use chlorhexidine gel. At least I use chlorhexidine gel always, so that it serves two purpose. It is an antiseptic, also it is giving you a interface to ultrasound can go.
Yes.
Sir, if there is beard and all that, will not the contact of ultrasound probe be a bit difficult?
That is why you have to use a good amount of gel. Or other option is you can cut it. So no one is preventing you, but it is not necessary every time. So it's
Yes.
your decision. If you can see it properly, if you can do it, because these procedures are very simple procedures, to be frank. Huh? And when ultrasound was not there, at least we have done, we are practicing since I am practicing in 2010. So in my initial years, there was no ultrasound in pain. So we have done all these procedures blindly. So even with our hand, we can understand where is the foramen and we are close to it. But definitely ultrasound gives an edge. Okay. So whenever you are facing such a situation, so it's your individual decision. But there is no hard and fast rule written that you have to every time shave the patient.
Okay. So I think you all can see the screen, isn't it?
Yes, sir.
Screen is seen, no? Okay. So first I will search for the supraorbital nerve. Okay, supraorbital, infraorbital, and mental nerve. So it is in one line only. Supraorbital I will search here, infraorbital here, and mental in this area. It is second premolar teeth. If you consider the teeth, so against the second premolar. So anyway, first I will see where is the supraorbital foramen through which the supraorbital nerve is coming out. So here first I will see the bony margin here, bony periosteum line, and then when I will see from down like this, not straight from up, not straight from above, I will see a bit from down. So then I can see a gap. So let us see. So here you see at this point there is there is all bone. Okay, there is at this point there is all bone. I decrease the depth a bit. So there is all bone. This is totally bone. Now if I come down like this and see from below, then I can see there is a gap. This is the gap which arises. Okay. Now I have to search a vessel here. So hardly you will see the nerve here. We cannot see the nerve. It is so small, but we can see the vessel. Yeah, we can see uh, the vessel running with the nerve. So color, if I give color, so there is a vessel and this is the gap. Okay, this is the gap, this is the vessel, and most likely this is the nerve. The arrow is depicting the nerve, this area. This is the nerve, this is the structure. Sometimes in some patient you may see a bit better, but otherwise we see in this way only. So here we locate the gap and we see the vessel, accompanying vessel. That's it.
Sir, I have a query.
Yeah, tell me.
Suppose you identify the foramen. Whenever you place the needle, like you deposit the drug inside that foramen, or you have to just come out a bit and inject the drug.
Yeah, I mean, hardly there is so much space.
No, sir.
See the depth here. It is 1 centimeter. Okay. So, I mean, in this area, if you inject a bit lower also, here also, then also the whole drug will be spread in the same area, in the, I mean, like subcutaneous plane. The whole plane will be, I mean, the local anesthetic will be deposited there only. Okay. So,
suppose it is an infraorbital foramen, sir. This foramen
yeah.
is a bit large. So you can enter into the foramen as well. So if you identify that, then you inject the drug inside that foramen or just
Yeah,
outside the
inside
foramen?
the foramen. Yeah, inside the foramen. Yeah.
Inside the foramen. Okay, sir.
Yeah, actually, tip will not go inside. It will hit the bone. But of course, it is inside only. Yeah, there is no point in remaining outside totally. It's not in the subcutaneous plane. So, yeah, here you see. So this is the vessel. This is the nice vessel we can see. This is the vessel, and here actually is the nerve. Sometimes I see, but some not. Sometimes it is the nerve. So just understand how to see the supraorbital foramen. First, you see the bone, straight bone like this, and then you see from below to identify the area, this supraorbital notch area. Okay, so this is the
So can you
area.
fix the picture?
Yes.
Can you fix the picture? I couldn't understand the anatomy actually.
I could not freeze at the point where the vessel was there. So, what is your question? I'm saying that this periosteum, can you not understand this gap? This is one periosteum, this is one periosteum, and there is a gap. If you remain a bit above, then you will get a straight line like this. And when you come down from below, when I see from below, then I can see this gap. Okay. So that is what I'm saying. So this is the supraorbital foramen, where you can expect to see the vessel, I mean artery, nerve, everything. But of course, the nerve is so small that we cannot see. This is the nerve maybe. So actually, artery we can see very nice. Okay. No, your question was something else.
So if you fix the picture and then let us understand.
So picture is, I mean, so
Using
this.
the color actually.
Oh, I should remove the color. So now
No,
there
use
is.
color. Sir.
Oh, okay. This is bone. This is the gap. This is the gap. Now the color. So as soon as I put the color, so this is the artery. I think you can perceive the gap. Now, I mean, freezing at a point where the artery is seen, it is a bit difficult. So this part is artery, and this part is nerve. Actually, nerve is not clearly seen. Nerve is not clearly seen, but we can see the artery, and this is the gap we can perceive. Okay. Now I see the infraorbital nerve. So infraorbital nerve also here it is the in the same way. So you see, as soon as I put like this, I can see the gap. Okay, this is the gap. If I go a bit high up, there is no gap. If I come down also, there is no gap. It is at some point. So this is high up. This is high up. At this point, I can find the gap. If you put this one, your color, you can see nicely the artery. Okay. So of course, we are not seeing the nerve isolated way nicely, but we can see the foramen. So in this view, you can understand that where is the foramen, and of course, you can put the needle in a out of plane approach. Okay, this injection can be a out of plane approach. So this is the infraorbital foramen.
So we have to be in the head end of the patient, and so that
What?
we can, for this image, should we be in the head end of the patient and you do an ultrasound and
Yeah,
inject?
yeah, that is possible. Yes, yes. Head end of the possible is head end side will be better, but then we have injected from this side also. I mean, it is not necessary, not hard and fast.
Okay.
Because you have to see in the ultrasound, machine also, no? You have to see in the screen. So how I am standing, that is also acceptable. Okay.
No, okay.
And you will see from here, and the injection will go, your injection will not go towards the eye. It will go like this from above to below. You will put the probe like this and go from above to below, like if you are going in the out of the plane approach. Okay. And here I am using a big this linear probe. You can use a small hockey stick probe also. That is also ultimately a linear probe only, but only the footprint is small.
Okay, sir.
So this
Thank
is
you.
so this is the infraorbital nerve. So both the things, ultimately we have to see that there should be a gap in the bone and then pulsatile artery. That's it. Okay.
The needling you said from other side of the eye or this side?
Yeah, other side of the eye. It is not very safe if you go from this side to this side. It is better from going from this side to this side. From above to down. When I will hold like this and go above to down.
Means I have to needle from the eye side, not from
Yes,
the.
yes.
Okay.
Yes. Maybe from the eyesight. Okay. Third one is mental foramen. So mental foramen is, I will just hold like this. I will just hold like this. So here also the same thing. Left side is lateral side and right side is medial side. So I will just see that where can be the gap. So this gap is not very big. This is a small gap. And remember, the opening of the foramen is always from lateral to medial. You cannot inject from medial to lateral. Opening is from lateral to medial. So your injection always should come from lateral. Okay. So here you can see. So now I'm showing you. So at this point, just keep your eyes at this point. So it is the periosteum. There is no gap. As soon as I go down, there is suddenly a gap. This area. So this is a bit tough to perceive. So this is a gap.
Sir, so I will hit the bone everywhere when I needle.
So
Actually,
I mean,
these blocks are very superficial blocks, but I am telling again and again. So what happens every time when you will be going, you just inject close to it. All are very superficial blocks. Okay, so we have to keep two things. Don't go too much inside the foramen because in that case there could be a chance of nerve damage. Don't give too much outside, then it will be whole thing will be subcutaneous. So just remain near to the foramen in all three blocks.
yeah, with your needle you will feel. So now see the middle part of the box. This is the foramen actually. This is the foramen, but you have to perceive that. Yeah, this is the foramen in the middle part of the box. There is a gap in the periosteum. Gap in the periosteum. Here I'm not getting the pulse. I'm not getting the pulse, but this is the area. So I'm not getting the pulse. So this is the foramen. Yes, in the middle part of the box. Middle part of the box. See, this is the mental foramen. So this is also ultrasound is much useful here because with when you are palpating by your hand, you may miss whether it is there or not. You may not be able to identify, but with ultrasound you can identify that, okay, this is the mental foramen. So this one, okay. I think everyone can perceive, isn't it? This gap. Of course, we are not seeing the pulsatile here. So this one. So your needle will always come from lateral to medial, always from lateral side to medial side. It cannot go from medial to lateral. Okay.
Sir, so in plane we'll go.
Yeah. This one in plane you can go. This one in plane you can go, but otherwise out of plane also you can go. Here, what I am saying is, as soon as you find the location of the area, I mean location, that where is the foramen, then it is less than 1 centimeter, 0.5 centimeter, what is in plane or out of plane, everything is same here. I mean, you can go directly, your needle tip is entering in a foramen, you will just feel it.
Sir, and regular needle only we'll use.
Yeah, normal 5 cc needle. Okay, so this much only. Then we will go with the next part. Just a minute. Stop share. Just a minute.
There is no voice.
Yeah, now. Yeah.
Okay, I have a question.
Yeah, please tell me.
All right, if a patient suffering of migraine, so
Yeah.
deal with this patient, a female patient, what type of intervention procedures we can do? How many, I mean, and do we have to block many ganglia? How number of them, or there are multiple trigger points? And what is the role of Botox in migraine?
See, already you have made the diagnosis of migraine. So if you would have told me that it is a case of headache, then I would have told you multiple interventions indicated for multiple diagnosis. But here you have fixed one
Migraine.
diagnosis. So for migraine, hardly there is any procedure which is evidence-based. There is no evidence-based procedure. Yes, Botox injection does have some role. So if there is a chronic daily migraine means 15 days at least continuous migraine. The patient have headache, continuous headache days is more than 15. Then only you will say that it is chronic daily migraine. In that case, you can go for Botox injection. So Botox injection is given in 32 points over the head, 5 unit, 5 unit, and it becomes like 155 unit actually. So that one can be tried. We have tried in multiple patients. So in a very severe case where nothing else is working, there you can go for this Botox injection. Otherwise, it is not a daily treatment because it has multiple shortcomings or side effects. because first thing is it is very costly. Then duration of result or duration of pain-free time is only maximum 6 months. Okay, after that again pain can come. So it is just like giving a drug holiday type of thing, that if the patient is already getting 10 drugs and now it is not working, so when you have given the Botox injection, then you can stop other drugs and again you can restart with one drug, so that the earlier drug which was not working, now it can work again. So like that. Third thing is it can produce antibody. Botox A produces antibody. So after 2 times, 3 times, 4 times injection, you cannot give Botox and expect a long-term relief, because a body will develop antibody. Okay, so this is the only intervention. And for migraine,
Can we get it for the sphenopalatine ganglia or only local anesthesia?
no, then your diagnosis should be sphenopalatine neuralgia, no? Then your diagnosis should be atypical facial pain. Then it should be cluster headache. In those cases,
In chronic headache, we can use sphenopalatine block for the chronic migraine, one of the indications.
no. For chronic migraine, sphenopalatine ganglion block, no. I mean, if you search the literature, then maybe you will find some people have done as a treatment they have used, but there is no good evidence.
But can be used in the chronic migraine. I think there is one slide mentioning that.
Yeah, I'm telling you that multiple literatures will be there, but I mean, big guideline forming organizations will not accept this actually. That's why. So you can try, if nothing works, you can try. But sphenopalatine ganglion block is for cluster headache, is for sphenopalatine neuralgia or atypical facial pain. It is not for migraine. And migraine also, I mean, there are two types. So one is vascular, one is cortical spreading depression, different thing. So sphenopalatine ganglion block doesn't directly treat migraine. Okay. Okay. So okay. So here we are talking about some interventions of the cervical spine. Okay. So some important conditions with which the patient comes to a pain clinic. One is your cervical facet pain. Okay, facet pain syndrome. So it can be of degenerative disease or trauma. So how a patient of degenerative disease can come? So nowadays, due to this mobile use, and those who are working in the IT industry, they will be sitting in front of a computer for multiple hours, no, 10 hours, 12 hours continuously. So those patients usually develop gradually cervical spondylosis, and it can become serious. So in those cases, sometimes you can find that someone has the cervical facet pain, so unilateral cervical facet pain. And trauma, so that is a different topic, that how trauma affects the cervical spine. So mainly here pain generator is cervical facet. So cervical facet syndrome is one diagnosis. Second diagnosis is occipital neuralgia. So occipital neuralgia can be greater occipital neuralgia or lesser occipital neuralgia. Of course, there is third occipital nerve also. So someone can have third occipital neuralgia also, but that is not very common. And of course, lesser occipital neuralgia also not very common. Only greater occipital neuralgia is more common. Now, third one is myofascial neck pain with trigger points in the posterior cervical muscles. So myofascial neck pain is very common in most of the cases. So where is the trigger point? Trigger point we usually get in the trapezius, levator scapulae or splenius scapulae, suboccipital region muscles. There are some suboccipital region muscles. So in those areas, it is the reason for the myofascial neck pain. So here, as I told you, cervical facet syndrome, it can be degenerative. Okay, so cervical facet syndrome, it can be a degenerative cause or trauma also. So trauma, there is a specific type of trauma that is called whiplash injury or whiplash associated disorder. So whiplash, remember, whiplash injury is very common in accident, but don't think accident means whiplash injury. Whiplash means a mechanism of injury when there is a forced extension and then forced flexion. So when and which type of accident? When it is a accident from the back, I mean, like you are going in a car and something has hit from the back side of the car. So in those cases only a patient can get whiplash injury. So this is a particular mechanism. Of course, a boxer or a player also can get whiplash injury. So during trauma also someone can get whiplash injury. So they also can develop a pain from the facet joint. Now, how the patient usually presents? So it is a localized neck pain. This pain can be localized only. It is not a radiating pain. Most of the time patient will say that unilateral pain. It is not even bilateral. Unilateral pain, it is in the same area and it is continuing for months and it is not radicular. Okay, and it worsens with extension and rotation. So remember, when we do flexion, there is more chance of extension, more chance of exaggeration of pain in a disc prolapse or radicular type of pain. Okay, but when it is facet joint, most commonly it is exaggerated by the extension or lateral rotation. Diagnosis, mainly clinical examination, but medial branch block is also a technique to confirm this pain generator. So there are multiple types of clinical examination where we stress the facet joint. Okay, axial loading, we do the axial loading and stress the facet joint to see that whether pain is reproduced from there or not. But sometimes it is many times it happens like this, that patient has come to you and you see that there is hardly anything in the physical examination or even the X-ray, MRI, everything is normal. In those cases, you go for a diagnostic medial branch block. So with a diagnostic medial branch block, you can you can be very much 100% sure that whether that facet joint is causing the pain or not. So management wise, NSAID, physical therapy, medial branch block and RFA. So remember, medial branch block means it is most of the time diagnostic block. So what is the definitive treatment? It is radiofrequency therapeutic treatment. Here, whiplash associated disorder, as I told you, that this is whiplash associated disorder doesn't mean facet joint pain. Facet joint pain is a part of the whiplash associated disorder, and whiplash means a mechanism of injury. Okay, accident doesn't mean whiplash. Whiplash is a mechanism of injury more commonly seen during accidents. So this mechanism, when there is an extension and then flexion in this injury, commonly it has been seen that facet joints are affected. Otherwise, sports injury, physical assault, they can also be a cause. So typical symptom: pain, neck pain, stiffness, headache, sometimes occipital headache is also there, and shoulder and upper back pain, reduced cervical range of motion, dizziness, visual disturbances, paresthesia in upper limbs, fatigue. And so these are some physical symptoms. But very surprisingly, a neck pain patient can present not only simple neck pain. If it is a whiplash injury syndrome, they can present with some psychological symptoms also. So they usually have this sleep disturbance, cognitive complaint like poor concentration, memory problem, psychological symptom, anxiety, irritability, depression, all these things. You will do an inspection to see that whether there is loss of lordosis and cervical stiff spine. Patient will come with stiff spine, muscle guarding, abnormal posture, all these things you will see. And then palpation, cervical paraspinal tenderness, trapezius spasm, trigger points, and facet joint tenderness. So all these things by palpating you can see. For diagnosis purpose, range of motion will be restricted in all direction. Neurological examination in facet joint pain or even the whiplash associated disorder, Most of the time it is common, but of course it can be, if it is severe, then it can be abnormal also. Whiplash rositor disorder can be multiple grade 1, grade 2, grade 3, grade 4. So grade 1 means no physical signs as such. Okay, just patient's complaint is pain. You don't find anything. Grade 2 means musculoskeletal sign. When you know that patient has come with a stiff neck, okay, you can see that, okay, range of motion is decreased and there is tenderness. 3 means neurological sign. 4 means fracture dislocation. So grade 2, which is patient when coming with neck symptom plus this musculoskeletal signs, these are the cases where we will target for the facet joint intervention for diagnosis. Okay, now intra-articular intervention or medial branch intervention, these two are only applicable for facet joint. Either you inject inside the joint with steroid local anesthetic, or you go for the medial branch with local anesthetic as a diagnostic block, then you go for radiofrequency for definitive treatment. Occipital neuralgia, as I told you, there can be two types mainly, lesser and greater occipital neuralgia. And earlier days we used to palpate, we used to put a make a imaginary line from the occipital protuberance to the mastoid process, then make it three parts, three equal parts, divide it. So at the junction of the medial 1/3 and lateral 2/3, that is the location of the greater occipital nerve. If you palpate there, you will get the accompanying artery pulsation. But nowadays we can see by ultrasound and we can inject on the greater occipital nerve. And since we can see at a much proximal level. We don't need this nerve to come out at a subcutaneous level distally, if we can inject in the much proximal level. Okay. So differences, so this is not needed. So there are, remember only one thing from diagnosis: neuralgia must be neuralgic pain. Be it occipital neuralgia, be it glossopharyngeal neuralgia or trigeminal neuralgia, the pain type should be different. So if patient's pain is coming from facet joint, most of the time it is a dull pain. But if it is a neuralgic pain, it is sharp pain, electric shock like pain, shooting, stabbing quality type of pain, and it can cause a paroxysmal attacks. Okay, so if you see the differences, so occipital neuralgia, it causes shooting, electric stabbing like, whereas the cervicogenic headache, which can be caused by a T2 T3 facet joints mainly, so in those cases it will be a dull aching pain. So facet joint pain is a dull aching continuous type of pain, localized pain, whereas neuralgia is a electric shock like pain, a dermatomal pain. Okay, so this is the difference. Ultimately, treatment for neuralgia is around the nerve, hydrodissection of the nerve, whereas if it is a facet joint, you will target the joint or the supplying nerve, the median branches. Okay, so myofascial pain syndrome, there is not much thing to say. Myofascial pain syndrome usually involves different parts of the body, but when neck is involved, mainly the trapezius, levator scapulis, planius capitis, these muscles are involved, and we will search for the trigger points. There are some specific trigger points in the muscles where we can go for the trigger point injection. Okay, so these three things, these three entities can come to us in a pain clinic, and Dr. Devjyoti will show you the facet joint intervention part and this one, your occipital neuralgia. Devjyoti. Any question here? Do you have any question?
Sir, I had the doubt. Epidural, whether the hub, needle tip, whether we keep up or down, is it important? Epidural when we are putting?
epidural, see, these are assisted epidural. You can see the depth, and then you remove the ultrasound probe, keep it at side, and you know that, okay, at this depth I should get. So, I mean, you get a idea that, okay, I'm not going too much depth, and I'm not going to hit the spinal cord. So this is a assisted epidural. So
No,
you
sir.
can just,
No, sir. I asked in cervical when we said interlaminar and all, the needle tip, it has that bevel-like thing. So whether up or down, does it matter if I keep that up or down?
no, it is not that much important. It is not that important in cervical epidural.
Like
This
if
bevel part.
whether the drug will traverse up if I keep the hub up.
No, these are not that much important nowadays. I mean, spread we are checking by giving contrast. We are giving contrast and we are checking. And ultrasound, as I told you, that we are not doing under ultrasound. We are doing under fluoroscopy. So though it is bevel is always in the posterior side, it is posterior directing, but it hardly matters. Your fluid is always, I mean, the drug or contrast is spreading upward. So you have to see that whether it is spreading upward or not. Only the bevel side doesn't matter. But bevel direction doesn't matter.
And steroid, we are using methylprednisolone or dexamethasone.
By the book, if you go, then it is dexamethasone. Okay, I mean, earlier we were using, now also I am using, but I cannot tell you. I mean, that guidelines is to go with the dexamethasone only. Yeah, in cervical spine, it is dexamethasone only.
Cervical spine, sir. These procedures today, which
No,
we did.
no, I'm talking about the epidural part in cervical spine. So that is the, oh, this one, you are saying the supraorbital, infraorbital, mental.
Yes, sir.
Here you can give dexamethasone, this one, methylprednisolone, dipomethylprednisolone, no problem. Here
How
you can
much,
give.
sir?
These are 10 mg or maximum 20 mg, 20 mg if you can give, if you, I mean, 20 mg.
Yes.
You mean to say in the peripheral nerve blocks for that trigeminal nerve, you give dipomedrol, sir?
See, no, I told you that diagnostic block is our main aim.
Yes, sir.
We want to diagnose and we want to go for the radio frequency. That is our main aim. So steroid is actually not needed, but in some cases where it is not, the pathology is at that places. Like say I got few patients of metastasis, infraorbital nerve metastasis. So problem is there only. So in those cases, if patient is not keen for radio frequency or they cannot afford, then you can give steroid there. Otherwise, if problem is not here, then directly steroid, there is no point in giving steroid here. Okay. But problem may be here also. As I told you, in metastasis case, we can get the problem is here. If you do a PET scan, you will see that I mean the infraorbital area or supraorbital area, there is increased uptake of the dye.
So
Okay.
if we have an overlap between the symptoms of the headache for the triggering points or for the facet joint or for the occipital neuralgia, we start with what? With the triggering point, then the occipital nerve block, then the medial branch block. With what procedure we start first? There's an
First,
overlap.
first you diagnose. First step is the diagnosis. So what is your diagnosis you want to start with?
Yes, I know. I want to do a diagnostic block. There's overlap of the symptoms of the patient. I want to do a diagnostic block. With what we start? We start with a triggering point, then we proceed to
No,
the.
no, no. See, diagnostic block also comes with a provisional diagnosis. If your diagnosis is facet joint pain, then only you will go a diagnostic block of facet medial branches. Okay. But if you are say diagnosing a case of occipital neuralgia, then diagnostic block of occipital nerve. if your diagnosis is a tension type headache, or say this type of your myofascial pain syndrome of neck, then this doesn't apply there. Then you have to go for trigger point injection. So clinical diagnosis is first step. Then comes second step as a diagnostic block.
You said in whiplash injury, if there is a neck stiffness and the muscle stiffness, how can we differentiate it from the myofascial pain and stiffness?
Yeah. So if it is a whiplash injury, then of course, first thing, of course, we will go like any other specialty will say that first you go with the all non-pharmacological and conservative treatments. Okay, after someone has done non-pharmacological conservative treatments, then you go for the simple trigger points. So after the trigger points are done, then you go for the facet joint intervention. If you see that if the facet joints, if you feel that this is the pain relief area, then you go for facet joints. So these two things only applicable in the case of the whiplash associated disorder.
Okay,
Whiplash associated disorder doesn't come with occipital neuralgia or say other type of thing. Okay.
Sir, I had doubt in radio frequency. We said we have to go to V3 and then we'll inject local and then do radio frequency ablation.
Which one? I forgot. I could not understand. What you
Sir, trigeminal neuralgia in previous class in radio frequency, we said we go to V3 first we get. We'll inject a little local and then we'll ablate. Then we'll go to V2.
No, okay. I mean, like, thing is that after you injected a local anesthetic, then you actually cannot stimulate anything. Okay, I mean, whatever you do stimulation, patient will not say, the patient will say, I don't feel anything. So stimulation part you have to finish first. After that, while you are going for this ablation, then you can give local anesthetic, and then if you put in the if you just move the position and say now you want to stimulate the V2, but that is you can do an extra stimulation to see that whether it stimulates or not. But earlier also you should have stimulated and seen that the V2 stimulation is there. Otherwise, if you have given local anesthetic, there is no option. You cannot see again.
Once V3 I have done, V2 is in a different location, no, sir. I have to go.
It is just lying at the side only. Local anesthetic 0.1 ml or 0.2 ml, you will give the everything is completely anesthetized. Distance is 0.1 millimeter or 1 millimeter say.
So I'll stimulate and then together give local and do RFA together.
Yes.
First to stimulate, yes. Because once you have given the local anesthetic, after that the stimulation, getting a stimulation is very difficult.
Actually, you know, many literatures do not support to give the local anesthetic. Many people, I mean, like many people practices also in this way that they do not give local anesthetic due to doing this stimulation only. Okay, so many people will give propofol. Many people will give fentanyl. So these things are there in the literature. But as far as our practical knowledge goes, patient goes on crying, shouting, so it doesn't look very nice that you want to relieve pain and you are giving more pain. So it is we do stimulation all in one setting, and then we understand that okay, this nerve is here, this nerve is here, then we give local anesthetic, and then anatomically we change and do ablation.
Can we do a V2 lesioning? I mean the conventional, and for the V3 we do the pulsed radio frequency. I mean,
you can do, but why? What is the benefit?
Because the V3 there is motor branches, or we do all of them lesioning conventional radio frequency?
Conventional is better because the motor weakness is not that pronounced.
Because
First 15 days or 1 month, it is a bit pronounced. After that, it reverts back. Okay, but we want the result of the procedure. Pulse radio frequency result is not very good, not very convincing. You cannot say with 100% guarantee to the patient that you will get relief. But with conventional radio frequency, most of the time we give guarantee that yes, you are going to get relief. So, but then of course duration may change, but patient gets relief 100% time. So I feel that nobody can stop you if you do a pulse radio frequency in V3. But as far as the pros and cons is concerned, I will say that go for conventional in both the things.
okay, thank you.
Sir, you have said you have seen a case of inferior orbital nerve metastasis. Which one was the primary site?
I could not get you. What you told?
Mm. You have seen a case of inferior orbital nerve metastasis. Which
Yeah,
one
yeah,
was the primary site of the tumor? I just, for my interest, I'm asking you.
yeah. Primary. That case I don't remember. Probably
What type
something
was the tumor?
prostate cancer was there or something like
Oh,
that. I don't remember.
uh-uh.
There was multiple
Someone
metastasis.
said
One
that
metastasis was there only here.
the patient was complaining of any facial pain only.
Yeah, only simple. This by the side of the nose there was a typical burning pain, and as soon as we gave local anesthetic, patient was very. I mean, patient was happy.
Oh, okay, okay, sir.
Actually, problem was not inside. Problem was just at the area where the nerve was coming out.
Okay.
Okay, Dajati, start.
Okay, let's continue. So today we'll be discussing two procedures. One is the medial branch block and the other one is the greater occipital nerve block. So let's first start with the greater occipital nerve. Let me show you a little bit of anatomy because it is very important. Otherwise, without knowing the muscular anatomy, it is difficult. So let us here first. Okay. So where lies the greater occipital nerve? First, we have to understand the muscle layers. The first, at the top, the muscle is trapezius. Trapezius takes origin from the portion of the occiput, the whole of the nuchal line, all of the spinous process, starting from the C1 to the 12. Upper fibers, they move towards the anterior side and down, and then they attaches with the portion of the clavicle. The middle fibers goes mostly horizontally and laterally. They attach with the acromion and the acromioclavicular joint. Whereas the lower fibers, they ascend and they join with the spine of the scapula. Now this at this area is a thin sheet of muscle. It remains at the top where we are going to block the suprascapular, sorry, the greater occipital. So let us hide this. After this muscle, we have two muscles. This muscle is known as the splenius capitis and this muscle is known as the semispinalis capitis. So at the top where we block, we see only one muscle, that is the semispinalis capitis, because the splenius capitis remains slightly lower and slightly lateral. So let's hide the splenius capitis and semispinalis capitis. Remember, greater occipital nerve comes piercing the semispinalis capitis. So from where it actually coming? If we hide the semispinalis capitis also, we got another muscle. This muscle is known as the obliquus capitis inferior or the inferior oblique muscle. Under the inferior oblique muscle, from the C5 root, this branch, the greater occipital nerve, which is actually the branch from the posterior division of the C2 cranial nerve, sorry, cervical nerve. So it is from the posterior division of the C2, the greater occipital nerve comes, and then they rotate along the lower border of this inferior oblique muscle. Then they remains in between the semispinalis capitis and the inferior oblique, and then the pierces the semispinalis capitis, and then the pierces the trapezius as well. And after piercing the trapezius, they become subcutaneous. So previous days, when there was no ultrasound, we used to block it at this point where it is coming out after the trapezius. for which there was a simple technique: just palpate the occipital protuberance and the mastoid process, divide it into medial 1/3 and the lateral 2/3, and then inject at the subcutaneous plane, and then we inject local anesthetic in most of the cases and come out. So that was the simplest technique. But now with the help of the ultrasound, we can block it at the deep where it is remaining in between these two layers. That means in between the semispinalis capitis and in between obliquus capitis inferior. Now, to know about the obliquus capitis inferior, we have to know the attachment of the obliquus capitis inferior. So, one side obliquus capitis inferior attaches with the spinous process of the C2. In the other side, the obliquus capitis inferior attaches with the transverse process of the C1. That is why it is so oblique. Okay, so we have to check in between the obliquus capitis inferior and over this muscle, and then we can go for it. Now coming to the medial branch blocks. For the medial branch blocks, we have to come from the lateral side, and if you see, the medial branches are rotating along articular pillars of the cervical spine that we have seen in the fluoroscopy and ultrasound. We can see these medial branches. So these are from the medial branch from the dorsal rami. They rotate around the articular pillar, and then they come posterior, then supplying the multifidus, also the facet joints, and there are branches which becomes cutaneous, which are the lateral branches. So to target this nerve, we have to target in a different way from this oblique side. So let us show you how to do this block. Just one second, let me arrange the.
Sir, audio is not heard. You're mute, sir.
So there are many ways to find out the C2 level, but the simplest way is to see the obliquus capitis inferior. Some says we have to check the spinous process of the C2. But remember, in all portions of the cervical area, this is only muscle that is going horizontally. All of the muscle fibers are usually in short axis. Only at the level of the C2, obliquus capitis inferior remains like this. So what I do, I usually search for a fiber that is going in direction of my probe. This is my probe, and I have to put it like this. So let's unfreeze and try to figure out. So I am trying to see. Now just move a little up and down, and now I can see a muscle that is going in a fashion that
Can
is
see
in
the
a
we can't
fiber
see the
Ultrasound,
that
scan,
is
sir.
the
the ultrasound
ultrasound
screen
image
is
is coming.
no, sir.
Oh, ultrasound image is not coming. Just one second. Just one second. Now I think it will come. Now it is coming. It's like this now. So now here you can see as I am holding it like this. Okay. So can you see one muscle fibers that is going along in long axis? Let me stop here and try to show you the muscles. Okay. So But at this point, we can see these fibers. They are going in long axis with the probe. My probe is like this. It is held from the C2 to C1, and we can see this is the muscle. So this is the obliquus capitis inferior. This is the spinous process of the C2, and this is the transverse process of the C1 transverse process. And here we cannot see similar fibers. So try to appreciate these fibers. These are fibers are going longitudinally. These are dot dot type fibers. They are not in the same. So this is the semispinalis capitis and this is the obliquus capitis inferior. And above these small sheets are the sheets of trapezius. So once we get this interface, it is very simple to get this interface. So we have to find and get this interface first, and then we will go slightly lateral, okay, in the same interface. And then you will be able to see in this plane a bubble-like thing, okay. So can you see this bubble-like structure in the interface of these two muscles? Visible?
Yes.
So this is the greater occipital nerve. So to block this nerve, either you come from the medial side or come from the lateral side. Remember, as the initial part, putting the needle from the lateral side seems easier. The problem becomes the needle visualization is better if you put it from the medial side, but it doesn't matter. So what is more convenient to you, you can perform that. You come from the medial side or lateral side and just go close to this plane. Sometimes it might happen that the patient is having a lot of fat. You cannot go and see so clearly the nerve. Then what you can do, you can just go to this muscular plane, in between these two muscular plane. Because if you give just 2-3 ml of the local anesthetic steroid solution, inject here, it will go and it will be around. So either you can go a muscular plane block if you are not able to see the nerve, or if you are seeing the nerve, then come as close as possible to the nerve and do not hit it, do not damage it, and then inject the drug around the nerve. So that is the greater occipital nerve block. It is if we given for the greater occipital
Block
neuralgia,
the nerve in the.
also for the sarcopenic pain. Yes.
Why don't we block the nerve in the head itself? What is the advantage of blocking this nerve in this muscular plane?
Result is much better. Yeah, I have done both. Okay? So in initial
Okay.
days, previously when we used to do, when ultrasound was not there, truly speaking, ultrasound
Sure.
came something in 2013 or 14. Before that, we used to do all blind or either fluoroscopy. So when with ultrasound we do, the result is excellent.
Okay. Oh.
Okay. So now we can actually see the nerve, and because there when we are doing in a blind way, what we are doing, we are just giving a subcutaneous injection, and we are expecting that this nerve will be there. Cannot see the nerve. Now we can see the nerve and we can inject directly to the nerve. Very simple technique, but very effective technique, and this is one of the most commonly done procedure in the cervical spine. So it works in cervical genic headache, it works in the retrooccipital neuralgia. Also, sometimes what happens, especially post-lockdown, we have seen a number of patients having the myofascial pain in this muscle, muscular spasm in these muscles, and there also the greater occipital nerve is trapped and the patient is having pain for long, and this also we can be treated by the greater occipital neuralgia. Nerve block, sorry, not neuralgia. Okay. So this is one simple technique, but very effective technique. Now we'll be going for the median branch blocks. So cervical median branch.
How much local hormone steroids there? 10 to 20 mg methylprednisolone.
20 milligram of the steroid is usually good, and I usually give 20 to 40 milligram, something in between, and along with 2 cc of local anesthetic. Okay, that means you most commonly my preparation is 1 cc of the local anesthetic and 2% lignocaine and 1 cc of the steroid. Okay, then inject usually 1 cc of it, depending how close I am. If I am giving in the plane, I sometimes inject a little more, that I am not able to see the nerve.
Yes, sir.
Okay. Now coming to the medial branch blocks. Remember, this is one block where the ultrasound is better than fluoroscopy. So here, to see the medial branch, especially if the patient is lean and thin, you will be able to see the medial branches very clearly. So to view a medial branch block, we have to scan like this. And from the superficial to deep, we'll be starting our scan. So what we can do, we can first remain superficial. We'll be able to see the cervical muscles. So what we are seeing, the both side trapezius and semispinalis capitis, all from a section. Okay. So as I am going deep, 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 then suddenly you will see, you will be able to start seeing these undulations. Okay. Hope everyone can see these undulations. Once you see the undulation, try to move up. Okay. Move up till you see the first undulation. So this is the first undulation that we can see. Yes, please. Okay. So this is the first undulation that we can see. After this, there is another undulation. And here we are having the C2 C3 facet joint. Usually this portion is the C2 C3 facet joint. Here remaining there is a bubble like structure at this point. Sometimes it is more clear, sometimes a little less clear. There are multiple bubble like structures like this. So these are the medial branches. So this is the first one, is the C2 C3. Next one will be C3 C4 and so on. So we can actually see all those, okay, from here. So first see the first one. Okay, then oh, I am holding it opposite. Okay, just 1 second. So here is the first one. Then I am coming. I can see the second one. Okay, and see these undulations typically in the lower part. That means here you can see at this point. Okay, just 1 second. So nice. Scribble. Just here you see the nerves. And if we go down again at this point, there are the nerves. Okay, again here is the nerves. Okay, so in each undulations on the basis, we'll be able to see the nerves. Now to block from this side, it becomes a little bit difficult because at this side there is the occipital bone that comes into our way. If you want to do it from lower side, then the problems come from the neck. So what we do for blocking the nerve, first select. Suppose we want to block between the C2, C3. So what we can do, here we are taking it just at the middle of the screen and then we rotate the probe like this. Okay? Rotate the probe like this. But we can directly see the nerve in a longitudinal view. Now we can see the nerve in a longitudinal view. If we freeze, I think again slightly increase करने से आपको अच्छा दिखेगा और now fine. Okay. So at this point, we can see this tubular structure moving from one side to other. So here lies the tubular structure moving from one side to other. So this is the articular pillar. And at this point, you can see this is moving from one side to the other side. So this structure is the medial branch. So what we can do, we can come from the posterior side and we can directly inject at this point. Remember, blocking at one level is not enough. So once you have blocked a level, we are blocking in between the C2, C3, then we have to block one level below as well. Okay. So here, as we are blocking the first level in between the C2, C3, this nerve, then I will come and I will block at this point as well. Okay. So here again I will do the same thing. I will change the orientation to 90 degree. Now I can see the nerve. Okay. Now I can see the nerve. So this will block between the C3 and C4. So here I will come like put my needle like this and then I will go and I will, this is the nerve, okay, rotating. Here my only advantage is that we see the nerve in long axis and rotating around it. So here we can exactly see it is rotating around this articular pillar, and nerve is rotating around the articular pillar. So we can directly inject to the nerve. So for one joint, we have to block at two levels, posterior to anterior side like this. This gives a huge advantage that we are away from the vertebral artery, we are close to the articular pillar, and we are getting close to the nerve. In that way, we can block the cervical medial branches. All right, understood?
Which needle you use? This normal needle or any special?
Always, ecogenic needles are always there. That gives you a little bit better visibility. But most common cases, we use the normal Quincke spinal needle because that is much, much cheaper.
Yeah.
Can we put the patient in a prone position or lateral decubitus?
Yes. So sometimes what happens, that happens for me also, especially if the patient is aged, patient is having a lot of stress at that time. If you do, sometimes we have seen patient to have the vesical attack while doing the procedure on sitting. So in those patients where we suspect that patient might go into the vesical, what we do, we make the patient prone and put two pillows just below the chest so that the neck is extended and one head ring. After that, we do the procedure in prone position. Okay, so it is possible to done in the prone position, and sometimes we do as well.
Okay.
Yeah, that question. So there
Sir,
are a lot of things in cervical spine, but these two are the most common procedures. Yes,
sir,
There
which one
please.
do you prefer, sir? Either ultrasound guided or fluoroscopic guided? Which
In
is
this procedure, when we are looking for the medial branch block, definitely ultrasound is good because what is the fact? In fluoroscopy, we are assuming all the medial branches are at the center of the reticular pillar. But in practical, when we see under ultrasound, they are actually not. So better you do under ultrasound and then we put a, see if you are having the radio frequency, then better put a radio frequency needle and then you stimulate. So in that way, you will be two-way sure that after seeing it, the nerve and after stimulating also. Now when you are confirmed, then you go for either radio frequency or injection, whatever.
there is a muscle attached to the articular pillar under above the arrowhead.
So what are those muscles by the sides? Let me go back. I'm just sharing again. So
And there is
just 1 second. I'm just sharing. It will be much easier for you to understand because there are multiple muscles surrounding it. So what are those? Apart from this, at this point, just look at what muscles we have. First, we have the trapezius. Just 1 second. Then we have this muscle that is the splenius capitis. It is named so because it looks like a splint. And then near at this point we have the semispinalis capitis. Then we have the splenius cervicis, and very close to it, that is remains the semispinalis portion. I have already said spinalis cervicis, and then it will come to the multifidus. So the most near muscle is the multifidus, and here there will be the longissimus, and just by the side there will be the longissimus cervicis, and at this point there will be the levator scapulae. So these are all muscles will be surrounding at this point. Okay. But as we are targeting only the bony part, usually the muscular identification is not that important at this point. But definitely, if you want to identify, you can identify each and every muscle. But though there are a number of variations and sometimes getting a differentiation of each and every muscles is a little bit difficult. Okay, so Chinmada, can you start the quiz.com?
Searching.
Okay.
Sir,
Yes,
I have a question.
yes,
Sir,
definitely.
ultrasound guided lesser occipital nerve block, how it is really?
The lesser occipital nerve, it is a small branch and it's a very, very small branch that comes from the superficial cervical plexus. So in few case patients, I with a lot of time and with this high frequency probe, so what I'm using is a 4 to 20 megahertz probe actually. So with this probe, I'm able to see that these small vessels. One is the great auricular, another is the lesser occipital. But every time seeing in every patient, it's not possible. In that case, the same way as we give in the superficial cervical plexus, just a little above, we inject in the muscular plane. Okay, it comes from the arch point and then goes posterior to the
DOCC,
directly the
Papado,
mastoid.
Toilet cow.
Okay, sir.
Doctor. Haunted IQ. A beta fiber. Bharat Narayan. A new clever lion. Nanometer. Dr. S. B. Lucky Heat. House Lovely Man. Cool Ice.
Kindly join fast. I'll start.
Dr. Boat. Uncle Fire.
Three people did not join. Anyway, I'm starting.
Quiz.com. Play and create.
Which of the following symptoms is most characteristic of occipital neuralgia? Sharp, shooting pain radiating to the eye. Which nerve innervates the C2-C3 facet joint? Third occipital nerve. Which nerve originates from the medial branch of the posterior root of C2? Greater occipital nerve. Which muscle commonly develops trigger points in myofascial neck pain? Trapezius. Which of the following blocks is used to confirm occipital neuralgia diagnosis? Greater occipital nerve block. Which joint is innervated by the anterior rami of C1 spinal nerve? Atlanto-occipital joint. The lesser occipital nerve most commonly arises from which root? Ventral ramus of C2. What is the preferred method for confirming cervical facet-mediated pain? Diagnostic medial branch block. Which structure is used as a sonographic landmark to identify the C6 vertebra? Chassanex tubercle.
Final question. Double points.
What is the most appropriate treatment for chronic myofascial pain with trigger points? Dry needling or trigger point injection?
Third place, Anusha. Second place, Nanometer. And the winner is Bharath Narayanan.
Thank you, sir. Thank you. Okay, Dr. Bharat Narayanan is the first place, so we understood. Yeah. Okay. So I think nothing else. If anyone has any question, please ask, or we'll call it a day. Okay then. Good night to you all. Okay.